Dear colleagues, as most of you being pediatric oncologists or pediatric neurologists or pediatricians might already know, high-risk neuroblastoma is a disease that despite offering multimodality or multidisciplinary care still comes with very poor overall prognosis. Especially when the disease is high risk, it's large in size, unresectable to surgically or is chemorefractory. We have very few options left to try to salvage or treat these little patients. One of the most important things in the care of neuroblastoma is the early diagnosis. Specifically for pediatricians, sometimes for neurologists, pediatric oncologists, it's important to make sure that the diagnosis of neuroblastoma is not missed. Most of you would know that neuroblastoma is a disease of the ganglions that is present around the spine and presents usually with a mass effect where the tumor has grown significantly large. It is exerting pressure on surrounding organs. It can be exerting pressure on the kidneys, is a large protruding mass when it is palpated by the parents, and can be quite a pain to treat because it tends to be quite chemorefractory. Now at Apollo Hospitals Bangalore, what do we do to give this edge for patients with neuroblastoma? First thing, we make sure to risk stratify them appropriately by running the appropriate tests, which is MYC amplification, 1p deletion, 11q aberrations, and making sure that the patients with higher risk are explained about the relatively poorer prognosis upfront. Risk stratification is important not just to increase the intensity of treatment. On the other hand, low risk or intermediate risk neuroblastoma patients do not require such intensive treatment, where the side effects of these intensive treatments can be avoided to a large extent. To give you an example, our high-risk neuroblastoma patients are subjected to long chemotherapy cycles of approximately 4 to 6 cycles, post which they undergo surgical resection or surgeries by our very competent pediatric surgeons or pediatric oncosurgeons. Post the surgery, we give the right amount of time before we decide when to start radiation treatment. So timing is one of the biggest drivers of prognosis in neuroblastoma, especially in high-risk stage 4 neuroblastoma. So post-surgery, radiation in a controlled fashion in the right amount to not hurt the patient, which is usually around 24 gray, is given to the tumor bed, enough to not cause the counts to drop and so that the tumor is treated adequately post-surgery. Now post-radiation, there are other options, specifically like autologous stem cell transplantation. Some patients might even require tandem, which is 2 autologous stem cell transplants, where the child will have to be admitted in the transplant unit for approximately 2 to 3 weeks. We give high-dose chemotherapy after collection of stem cells, and the stem cells are given back to the child so that the highest dose of chemotherapy can be delivered to kill all the neuroblastoma cells, however not sending the patient into aplasia. Post this, patients would also actually qualify for dinutuximab or anti-GD2 antibody, which has been shown in Western countries to have great survival benefits or to increase the prognosis in these patients. However, this does come with a slight cost, and this we can discuss eventually when we have a patient who passes all these treatment phases or regimens and is ready for immunotherapy or dinutuximab. Despite offering all of these multimodal approaches to neuroblastoma, it can still be quite tricky or quite complicated to treat these patients, and disease might still come back. There is, of course, a treatment called MIBG therapy, which can be offered to patients, which comes with some benefit, but overall the prognosis then remains poor if these patients don't respond to all the mentioned modalities of treatment. If you have any doubts about managing neuroblastoma patients, I can definitely help out in titrating or creating that treatment protocol back in your country, because that can be delivered safely over there under supervision. However, if these patients require radiation, complicated surgery, or autologous stem cell transplantation, they have to be referred to India for these high intensity or highly specialized treatment modalities.